So our next speaker is Mrs Monica Thornton. She's a therapeutic radiographer here at Royal Derby Hospital, and she's worked here for the last 25 years, which is incredible. In 2018, she became the lead therapeutic radiographer of a small team tasked to establish and run the Derby Macmillan Radiotherapy Late Effects Service. This is a bespoke service which supports cancer patients with any physical or psychological late effects as a consequence of their radiotherapy treatment. They offer a holistic and personalised approach, and the service focuses on supporting the person, not the patient, managing the impact of late effects as well as the late effects themselves. The service has currently helped over 500 patients so far to understand and manage their late effects and live their best life possible after treatment ends. So thank you so much for coming to chat to us.
Thank you for having me. Can everyone see the slide okay?
Yes, we can.
Yep, okay. So we're going to be talking about how our radiotherapy late effects service helps to optimise the management of radiotherapy late effects after endometrial cancer radiotherapy. I'm going to start by explaining why this service was needed. As the number of people surviving cancer grows, so does the number affected by late side effects of treatment. People are also living longer, now presenting with late effects even decades after cancer treatment. Radiotherapy is often used in combination with surgery or chemotherapy to treat gynecological cancers, and an estimated 67% of women survive more than 5 years, with reports indicating that over 50% experience some sort of long-term problem. For effective cancer treatment, radiotherapy involves also treating surrounding tissues and body parts, and the damage done to these areas can lead to late side effects, as shown in the slide, which is collectively classed under the umbrella of pelvic radiation disease, or PRD. A patient once said to me, "I was cured of my cancer, for which I am grateful, but I was robbed of any quality of life." And that made me realise that when treating cancer, we talk and think about survival, but patients don't just want to survive cancer, they want to thrive. And if their late side effects are limiting or preventing them from leading a good quality of life, then we must take some responsibility to help and support them to lead the best life possible. In 2018, in recognition to the fact that cancer doesn't always stop when treatment ends, Macmillan funded a 3-year pilot of the radiotherapy late effects service, and this service has since been taken on by the Trust and is now a full-time service. We see all patients of all cancer types, providing that they received radiotherapy 6 months ago or more, and who are now having physical or emotional late effects due to their radiotherapy treatment. We work as the link between patients and the services that they require, communicating and coordinating care within the Trust, GPs and community-based teams, and with community projects and charities. We also educate patients and staff on radiotherapy late effects, attending patient support groups, staff education sessions, conferences and study days. We strive to make the support and advice that we give relevant for each patient, addressing their needs whilst taking into account their lifestyle, culture, capabilities and means. If we identify a gap in patient care, we look for ways to either fill this gap ourselves or facilitate bridging that gap in collaboration with other services or charities. In the last year, we have formed the East Midlands Late Effects Collaborative, together with the late effects services in Nottingham, Lincoln and Northampton, and hopefully once Leicester have a late effects service, they too will join. This group will help to look at the care and needs of cancer patients on a bigger scale. By sharing data, resources and ideas, we can help give a bigger voice to our patients, learn from each other and hopefully achieve more. There's a few radiotherapy late effects services now nationally, ours being amongst one of the first to establish, but only a few like ours currently see all cancers. Some are focusing on certain areas or on specific late effects, such as radiation cystitis or gastrointestinal late effects. As late late effects services have increased, the Society of Radiographers have formed a special interest group, and as current chair for that group, I shall be hosting our National Late Effects Study Day here in Derby later on this year. We began seeing patients in May 2019 and have had almost 500 referrals in total to date. Of those, 442 have been eligible according to our criteria. I've listed reasons for non-eligibility on the slide. These patients were signposted to the most appropriate service or websites. Occasionally, patients are referred to prematurely whilst awaiting results for investigations and then being identified as having disease progression or recurrence. This is a particular risk for patients with gynecological cancers. So should you suspect recurrence, please rule this out before referring them to us. So almost 3/4 of the patients we see have received pelvic radiotherapy, predominantly for prostate cancer, but gynecological cancers make up the second largest of this group. And of those gynae patients, the majority have had cervical cancer. This slide shows our referral criteria and how to refer. Any healthcare professional can refer to us by post, email, or phone. Most patients have been referred within the first 3 years of finishing their radiotherapy, which is when late effects often present. These patients are being identified and referred mainly in the follow-up clinics. Other referrals have come from gastroenterologists, clinical nurse specialists, therapy radiographers, the lymphedema team, and even a GP. These patients are the fortunate ones, being under the care of professionals who can identify radiotherapy late side effects and refer them to us or other specialties for appropriate care. But what about those no longer on active follow-up? We also accept self-referrals, which account for approximately 1/4 of all our referrals. We have seen gynae patients who are 10, 16, even 24 years post-radiotherapy, having found our service through support groups, social media, and registers like that on the Pelvic Radiation Disease Association website. Reports produced by Macmillan and more recently Joe's Trust have shown that patients cured of cancer and discharged from follow-up are at risk of being misdiagnosed and struggle to access appropriate care. This is one thing that we can change together. We see patients regardless of how long they've had radiotherapy treatment. So please, when discharging your patients, do 2 things. First, remind them of the potential late side effects so that they might recognise symptoms themselves as possibly relating to their radiotherapy. Secondly, inform them that should they develop any issues in future, then there is help available, and pass on our cards so that they can self-refer to us if needed. This will hopefully reduce the number of patients being misdiagnosed or who ricochet between multiple GP visits and various specialties before they receive an accurate diagnosis and appropriate care. After receiving a referral, we triage call to confirm that the patient does in fact have late side effects potentially caused by their radiotherapy treatment. Often, the reason for referral is the classic symptoms of pelvic radiation disease, involving the bladder and bowels and having pain. Should this be the case, we send out appropriate journals such as a food and symptom diary, a bowel diary, a pain journal, to be completed ready for review in the new patient appointment. When patients are referred to us, it is often for medical symptoms, but when patients self-refer, usually it is the consequences on daily life which they are seeking help with. These consequences can have a significant emotional and mental impact. We have had patients saying that they feel suicidal, desperate for help, and feeling guilty for appearing ungrateful to have been cured. A few regret having treatment because when they had cancer, they could name the reason for their issues and pain, but curing them took away that reason, and they can't explain why they have these late effects now. So to manage late side effects, it often isn't enough to address the physical side effects, but also to understand and help with the impact that it has had on a patient's daily life and on those around them. To help us understand this, we offer the Macmillan Holistic Needs Assessment, or H&A, which allows patients to identify emotional, practical, spiritual, financial, and social concerns, which they can then discuss in their appointment. This is an opportunity to raise concerns which patients may have felt embarrassed to mention, or thought there was no help available, or that they've not been entitled to help now that they've finished treatment. These are a few of the more frequent concerns raised in the H&As completed by gynae patients. It can be like opening Pandora's box, but often the concerns link in with one another, and once you start to manage one, it has a domino effect, facilitating the manageability or resolution of other concerns. It can also highlight barriers, which make addressing some late effects more challenging. For example, work patterns and time constraints might make patients more reluctant or unable to make dietary changes to help with bowel issues. So as you can imagine, discussing these late effects and its consequences is emotional for patients, but it also takes time. Time is one of the things that is most valuable for us to offer. The new patient appointment on average is 1 to 1.5 hours long. It is patient-led, their chance to get off their chest their questions, worries, fears, concerns, some common things being shown on the slide. As therapeutic radiographers, we understand the treatments being given and what was done when planning and giving the radiotherapy to minimise the risk of developing late effects and the severity of them. Being able to talk patients through this treatment, even show their plans on screen, can help them to understand their treatment and side effects now. Taking the time to explain why late effects present months, even decades after treatment, helps with acceptance and facilitates the next step of addressing concerns. This is particularly important for patients who are stuck in their situation, unable to let go from their anger, their guilt, confusion, especially when they believe that they have been informed of a potential late effect and not in understanding it. As professionals, we know that potential risks and side effects are part of consent, but at that time, patients are more focused on starting treatment and then recall little of that initial consultation after treatment ends. So it's worth considering as well how patients have interpreted the information being given. For example, loose bowels. It can potentially be likened to having an odd bout of diarrhea, which seems manageable enough. However, radiation-induced bowel side effects is very different, and if severe, can impact on daily life in many ways. Some patients have reported becoming almost housebound, restricted by their toilet dependency and feeling guilty for being unable to work or do a school run. Explaining things more clearly to patients from the beginning and reiterating this throughout their cancer treatment may help prepare patients better for these late symptoms and potential impacts, possibly identifying these effects sooner and seeking appropriate help before the consequences escalate. During the appointment, we ask questions like the one on the slide to help identify the patient's needs and priorities. We like to establish realistic expectations and goals and decide together how to proceed. This patient-centred approach is important because many patients report feeling out of control, having lost their identity, sense of purpose and confidence. We also discuss possible barriers and challenges and brainstorm potential solutions together, tailor-making the advice to patients' needs and capabilities. I had a lady who spoke limited English, referred to us for recurrent UTIs and urinary leakage. We established that her work environment made it very difficult to implement the advice being given. Due to limited toilet breaks, she drank less before work, believing that this would reduce her need for the toilet, and she struggled to hold at work, leading her to be in pain and leaking. She felt unable to speak with her employer due to embarrassment and also the language barrier. So I wrote a brief letter for her to take to her employer, stating how, due to her medical condition, it would be helpful for her to go to the toilet when needed and have access to a drink bottle to keep hydrated. This helped to improve her work conditions, and she even used the urgent toilet card I gave her to discreetly notify the supervisor when she needed to go to the toilet. Enabling her to implement the healthy bladder advice resulted in her being discharged after just one follow-up, having reported no infections or pain and improved bladder control. Promoting self-management and involving patients in decision-making gives patients a sense of ownership in their care and increases the likelihood of compliance and success because patients have chosen what they feel comfortable and confident to try. This slide shows some of the main ways that we help patients with pelvic radiotherapy late effects. Any dietary advice we offer is based on a 7-day food and symptom diary, so you tailor advice to a patient's own eating habits, culture, and dietary needs. We also provide healthy bladder and bowel advice, explaining irritants, toileting habits and posture, hydration, and pelvic floor exercises. Simple but effective advice. Many patients report fatigue, and we help to explain the difference between general tiredness and cancer-related fatigue. We explore the factors possibly contributing to their fatigue, poor sleep habits, medications, mood, the activity, and where they may be losing energy, for example, with pain and worry. Patients are shown how to assess their energy levels and how to plan, pace, and prioritise their day to avoid burnout. By learning how to adapt your day according to your energy levels and addressing the contributing factors for energy loss, fatigue can improve over time. Many ladies have difficulty explaining their pain, often because there are multiple causes for the pains in their pelvis, all impacting on each other. So we talk through ways of describing and recording pain, the perception of pain, try to explain possible causes and how to manage it, and referring to specialists when needed, such as the chronic pain team. As I mentioned before, a lot of our patients require emotional and psychological support, whether that is help with guilt, fear, or anxiety, or exploring what their life values and focus is now. We provide time to listen to their thoughts and explore ways of managing feelings and mental well-being, utilising talking therapies, relaxation and mindfulness techniques, complementary therapy, and courses like the HOPE programme. We also encourage patients to engage in physical activity programmes, support groups, and social events to help with mental well-being and physical health. We always work within our scope of practice and refer to other specialties when required. You may have noticed on the slide previously that sexual health was mentioned, and this is the side effect I previously dreaded, because as a radiographer, this subject simply wasn't taught in my training. At most, I was told of the importance of using a dilator, focusing on making clinical examinations and sexual intercourse easier and more comfortable. And I think little has changed since I qualified some 25 years ago. But addressing sexual late effects goes beyond dilator talks and asking if patients are sexually active. In 2020, Dr. Lisa Ashmore, a radiographer and researcher at the Lancaster University, began the Gynae Cancer Narratives Project. It explored how patients experienced radiotherapy for gynecological cancers, using patient journals from consent to 6 months post-treatment, and focused on how patients coped with radiotherapy, their expectations, and the levels of support they needed and received. The findings were then published along with a patient quotes in a book called We Need to Talk About Radiotherapy for Gynecological Cancer. This is written for professionals and patients so that both sides can learn how to change the care and experience received through the reflection of patient experiences. After reading it myself, it certainly made me more aware of how the assumptions that we make and the language that we use can alter experience and, more importantly, a woman's perception of their own appearance, femininity, and sexual being. Some quotes, like the one on the slide, can be hard to read. After the book, this project then worked together with me and her sexual pleasure workshop facilitators, exploring the language and barriers and fears that professionals have around conversations about sexual pleasure, and then helping to develop resources to aid these conversations. I was fortunate enough to be among a team of 15 radiographers from across the UK to work on this. Although at first I found this workshop quite embarrassing and at times very uncomfortable, it really did help to improve my knowledge on the subject, helping to build my confidence to talk about sexual well-being, and it gave me a lot to reflect on. This is what I learned from the project. If a patient feels comfortable enough to ask about sexual health, then we should not be afraid or embarrassed to engage in that conversation. It's okay to not know the answers. Patients will appreciate the opportunity to discuss and value any signposting that you can provide, even if that means researching the answers and providing them later. Remember that it's not just about penetrative sex, but sexual wellness. Some ladies with late side effects continue to see their intimate area as a medical problem and no longer feel capable of receiving or giving pleasure. It is just as important to help women feel feminine again and to learn to love themselves. Patients have asked about libido, how to communicate with partners about their issues, or start becoming close again. Some have asked about sexual aids or sexual positions, or how they could prepare practically and emotionally as a couple for those possible oops moments during sexual activity. We are lucky in Derby to have nurse specialists that we can refer patients to for help. But unless we are all willing to talk and ask patients about their physical and emotional sexual wellness, how are we going to know to refer them? And let's not forget about feminine care. I have found that sometimes, unless you specifically ask about vaginal dryness and tightness, patients don't mention it. Some women have thought that this is just something that they must now live with, expecting this more as they age. It's surprising how many ladies don't even associate vaginal dryness as a source of their discomfort or as a factor potentially contributing to recurrent infections or pain. This is especially true for patients who finished treatment a decade ago or more, because back then this wasn't openly talked about, and many products available today, like the Yes products, simply didn't exist, and their use can have a huge impact on women's health. I mentioned the Gynae Narratives project resulted in some free resources being created. So there is a poster, practitioner cards, and patient cards. The link is on the slide so that you can order these for free to help you with these conversations. Going back to the clinic setup, when it comes to follow-ups, we agree a time frame for with the patient. We recognise that everyone has their own way of learning and support preferences. Our letters are written to the patient for the patient in layman language, with their GP and other professionals involved in their care copied in. We discharge patients in agreement with them that their late effects have either resolved or are now manageable. On average, this is after three or four follow-ups. But we do have some very complicated patients with multiple comorbidities that often need a multidisciplinary approach to manage their issues, so they remain under our care for longer. Others have been discharged after just the initial consultation, satisfied with knowing more about their current and potential side effects and where to get help if needed in future. For a few patients, the best outcome is that we tried, but they are discharged understanding their symptoms better, knowing how to manage the best that they can and the options that there may be in future should some symptoms worsen. All of our patients leave knowing that they can refer themselves again if needed in future, a lifetime membership to the service. And this is not just because late effects may develop or worsen, but also because circumstances can change, making late side effects harder to manage or symptoms previously not a concern becoming one. For example, a new relationship creating concerns regarding sexual health. What we have learned through providing this service is that no two patients are alike, which this slide demonstrates brilliantly. Late effects is not just about the physical symptoms, it's the impact it has on a person's quality of life, their perception on life, and their capabilities. Managing late effects is complex. It takes time and is unique to each patient. It's difficult to evaluate the effectiveness of a service like ours, but from the regular comments that we receive, some of which I've put up for you to see, we know that patients find it invaluable. For us, it's really rewarding to see the transition of a cancer survivor referred, feeling and looking like a patient again, being discharged from our care as a person again, back in control of their life and ready to lead a better quality of life. I have listed some reports, guidelines and resources which may be of interest to you. We continue to learn in this service and are constantly looking for other specialties, services and groups to link up with and learn from. So if you see patients with radiotherapy late effects or provide help for their symptoms, we would love to hear from you, so please do get in touch. Thank you for listening. Are there any questions?
Thank you, Monica. That's been a fantastic talk. Have you got any comments at all, guys?
There's just a hand from Jayshree.
Jayshree, do you want to just put your camera on and ask your question?
Sorry. Hi. I'm just trying to get the camera on. I think, should it? Yes. Hi. Thank you so much for your talk, and it's great to see late effects being on the agenda today. We're trying to do similar, in the Northeast, and I'm currently part of a steering group looking at this. We cover quite a bit of the region in the Northeast as well, and currently the issue we have is, so say I have to refer to somebody to a gastroenterologist. It's wherever they come from in the region, and certain gastroenterologists may not have the required expertise to deal with these late effects. And I was just wondering how did you set up that service, especially when it comes to referring to other specialties?
Yeah, it's very difficult. When we first set up, we wanted a really robust, very clear pathway of how this is going to work. One of the challenges we face is that we are radiographers, and quite often referrals are consultant to consultant. So, it's about building a relationship with key people. And so we have an understanding with some gastroenterologists that when they see patients, they diagnose them. And for example, if they have proctitis and it's mild, not required in any treatment, then we monitor them. And if things worsen, we can then contact that person back to say, can you actually assess them again with and possibly treat? And so we take away the need for another consultant to actually see them, because we're doing that and organising, you know, arranging the testing and things. I would say it's always changing as well. Sometimes it depends on key people in a service, you know, but we also have quite a few of people in Burton, for example, in different areas where they would go elsewhere. It's, I think, difficult but doable, and it's about meeting up with all those different people and actually finding out if they are happy for you to contact them and what is the best way, you know, and it might involve by going backwards and forwards and sometimes changing how you do things, but they do get on board when they start noticing just how much of a difference it makes.
And can I just ask, are you routinely testing for, say, things like bile acid malabsorption or small bowel bacterial overgrowth within your service?
So we don't. I'm aware of some services do. Some people have found that actually you can actually have that and be not symptomatic. So in some ways, what are you going to gain if you have someone that actually hasn't got it, that's being routinely tested for it, and then they're thinking, I've got yet another condition. I think if they are actually explaining that they have got these symptoms, then we do refer to get those tested, but they've been few and far between, and only one person's come back so far with something like that.
That's great. Thank you so much. Thank you.
Any other comments? Any other questions?
There's a hand up.
Kamana Subba, do you want to just take your camera on, put your camera on, and then ask your question?
Thanks, Monica. Just trying to find any services that would cover West Midlands, because I know a patient who's really struggling post-radiation. So I went through that website just now after I was very impressed. There's a service like that, because I was referring to community palliative, blah, 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 and doesn't seem like she's getting the right care, support. Anywhere I can refer her, like, because it's really affecting her life. Thank you.
So what symptoms has she got?
So bowel and bladder incontinence. So
Right.
Yeah.
And where are you based? Wolverhampton?
Yes.
So there is a late effects service being set up. I am currently trying to get a list of all the different services. I think one of the difficulties is that we all sort of class ourselves as late effects services, and we're a radiotherapy late effects one. But as I said in the presentation, some people, like Guy's Hospital, have got a cystitis clinic, radiation cystitis clinic, but they don't see everything else. So it's about, you know, you can look for a title, but it doesn't mean that that patient will be able to get there. So we're trying to get clearer signposting, I think, of services. If you want to email me, I can certainly let you know of services, but I'm sure that we have got someone in Wolverhampton looking at setting one up, and I can let you know of a radiographer there that might be able to help.
Will be amazing. Thank you so much.
Okay.
Is there any option to cross-refer in between while if they're not got a service set up, Monica?
So we are not funded to see patients officially, but what we have done is I have had some patients from out of area. So from Leicester, and someone else phone up from elsewhere in the UK that don't have a late effects service yet, and there is a lot of help that we can signpost them to. So, you know, there are, you know, websites and things, and we can let them know of what to go to their GP for, and the registers and things. So, for example, on the Pelvic Radiation Disease Association website, they also have a list of specialist dietitians that do take on patients from anywhere in the UK. I'm aware of a service that sees patients regarding sexual function anywhere in the UK. So, you know, it's we can signpost them that way as well.
Okay, thank you. Fantastic. So that completes your talk. I think if we move on, it's been obviously a fantastic day. Has anybody got any questions that they want to put to any of the faculty who are still on that you haven't not had a chance to ask? I think this is probably a bit of an open forum, maybe for 10-15 minutes. Jayshree, what would you like to ask? Who would you like to ask?
Hi. Just going back to low-grade endometriomes, I'd be very keen to know what other centres are doing in terms of Are you doing pre-op imaging? It's always a bit of a debate with us. A lot of centres don't have funding for pre-op imaging with MRI, and
Yeah,
it does become a bit of a
we do MRIs on all our endometrial
all.
cancer diagnosis, whether they're grade 1 or grade 3. High grades get CTs as well, but all the grade ones all get you know, an MRI. Occasionally, you might think, you know, they're all going to be early stage, but we have been caught out where, you know, the disease is far more spread than you anticipate, or there's greater myometrial invasion, and actually the final histology turns out to be more advanced than you first thought, and you have to adjust your management. In addition, it also guides into your, you know, to make into your route of treatment. The vast majority of these are done by laparoscopic surgery, but and we will manage cases at you know, 8-9 centimeters in AP diameter laparoscopically. But even if they're slightly bigger than that, you can just still do it laparoscopically. May do a little incision to get it out whole. So we do it on everybody.
Usually we've been caught out where they have post-op imaging and then they have nodes and you don't know whether they're reactive nodes or. So have you got any suggestions or advice as to how I can push this for my own MDT as a clinical oncologist? Because so far I've been met with quite some resistance.
As far as my other guidelines should state that the MRIs, you know, it should be done. Yeah.
Okay.
So implement it into your guidelines.
Okay.
Yeah.
Thank you.
Okay. Kamana, have you got another question?
Yeah, I'm like, it's about the Lean syndrome. There's evidence about the aspirin, fiber diet, and all those things. So I looked at the literature. I'm still not sure of what, like, who should prescribe the aspirin, and then what's the dose? Because there are 2 patients who have been diagnosed with Lean's, but from our side, gynae, like, it's our cancer, but we refer to colorectal team so that they are on the loop for colonoscopy, all those things. But my patient, they told that the GP had literally no idea what was they dealing with. So they were asking about aspirin. So also there's like so much diffusion of the responsibility. We say colono and colono said, like, you know, the GP. So just wanted to ask, like, what's the consensus or what your advice be, whoever, like, in Lean syndrome, please.
I think Neil is no longer on the call, but we can ask Neil that question. Are you aware of anything, Susie or Anna?
Neil said in his talk today that there's still no consensus on the dose. So I think it would be a matter of having to review the evidence, maybe discussing with the familial cancer clinic in terms of their experience. And then, you know, as a parent clinician, just being prepared to then prescribe it for the patient and the GP to continue, as long as you can find some evidence base for it. But it seems there's no consensus at the moment.
Okay, yeah, because there were some studies comparing different doses. And yeah.
Okay. Suzanne Booth, do you want to just put your camera on and ask your question?
Hi, yeah, it's Sue Booth here. I'm a gynae oncologist in Hull. It's been a really good meeting. I've really enjoyed it. The thing I wanted to ask was about the your treatment of endometrial cancers in Derby. There was just a few things that have come up throughout the day, some from what the patient had said as well. Do they have a hysterectomy and then do you sometimes go back and do a lymphadenectomy? Or have I misunderstood that?
Well, generally we will triage those patients who are, we do an MRI on everybody and then decide on which patients are appropriate for sentinel lymph node biopsy, and we're doing lymph node dissection as well at the moment because we're just in the transformation zone point, going from just sentinel. So we do both at the moment. Occasionally we're caught out where we thought it was a grade 1 and it ends up being a high grade. And in those cases, we do offer patients sometimes a systematic pelvic lymphadenectomy, because some of those may then avoid complete pelvic radiotherapy and may just, if the lymph nodes are negative, they may well just get away with brachytherapy. So that's not done as a routine. That's done in some cases. And again, patients are given the choice. Do they want to go through a second operation and potentially avoid the full pelvic radiotherapy for just brachytherapy? Or do they just want, you know, if they're very high risk, then occasionally we just give them radiotherapy. But that's not
also when we have extensive lymphovascular invasion on hysterectomy. So sometimes we find a grade 1, still a grade 1, and it is a 1A, but happen to have extensive lymphovascular invasion. So that's when we go back and offer the patient pelvic lymph node dissection.
So if they have a lymphadenectomy and all the nodes are negative, you're not going to give them adjuvant radiotherapy.
Sometimes, I mean, it depends on what the original histology was, but some patients may, had you not done the lymphadenectomy, you would have had to give them pelvic radiotherapy. And so you then just, if the nodes are negative, you end up just giving them brachytherapy. Other patients may avoid radiotherapy altogether.
Okay.
There is a sort of crib sheet that we use. We can forward that to you as a guideline if you wanted to.
Can you forward that?
And it's often a good recap. We often end up having to refer it to ourselves
all the time.
Yeah, because we will forget the little, and with the introduction of molecular staging, and that's going to become even more complex. So I'm sure we're going to have to use that crib sheet that Neil gave or somebody put up. I'm sure I took a photo of it during the day actually, because I thought that'd be quite useful.
Okay.
Yeah, so it's all in line with the ESCO guidance. So we only go back and do lymphadenectomy as a secondary procedure if they've been upstaged or upgraded. Post-operatively, that would shift them into a different risk categorization, but we wouldn't do it as standard as a two-step procedure. And if it involves a secondary surgery, then we would have the discussion with the patient about going back then to do lymphadenectomy versus then as an alternative having external beam. So weighing up their options.
I understand what you're saying here, but if you could forward on your crib sheet.
Yeah, we can try. We can. Would you just, Sue? Would you just email me anyway, because I'll have forgotten by the end of this meeting. So
yeah, no problem.
Just email me and I'll forward it to you.
Okay, thank you.
Yeah. Are there any other questions or comments? All that left for us to do is to wrap the day up, really. I just wanted to say a big thank you to our course organizer and faculties, our speakers, for all their time and effort they've put in. Thank you particularly to Anna, Susie, Jane, Aisha and Harriet for helping with the day today. It's been a fantastic program. Thank you to all the speakers, Rand and everybody else who's spoken during the day. I think it's been a very interactive day. If there's any other comments, what I would like everybody to do is just put their cameras on before you sign off, so we can see how many people are still out there. There's still 175 people out there on a Friday afternoon at 5:30, which is, I find, quite astounding. Most people are skived off. I think we got up to 320 or 30 during the day with over 450 people registered. But just wave as you go, sign off. Is there anything else to add, Susie, Anna, or Jane, please? Any other comments, Susie, Anna?
Just thank you to everyone for coming. I really hope you've had a good day.
Agree. Yep. Just thank you to all the speakers and to Mr. Abdul, of course, and the CNS team as well, who've been working in the background. So thank you very much.
If you we'll send you a feedback form as long as you've been registered, and then what we'll do is, once you've filled out the feedback form, we've tallied you and make sure you've obviously attended. We'll send you a certificate. We've already got a date for the following year's programs. There's a whole load of other programs you can attend. There's a endometriosis symposium, an HRT course, and various other things. A TLH course for those of you who can't do a TLH in an hour. All right, so we'll sign off there. Thank you. See you guys. If you just turn your cameras on and wave as you go by, that would be lovely. Okay, see you guys. Have a good weekend.
Thank you. See you. Bye
Jane,
bye.
thank you.
Bye.
Thank you.
Bye.
See you guys.
Thank you.
Thank you. Thank you very much. Thank you.